before this falls over. Hi, good morning, ladies and gentlemen. Doppler. Conflict of interest declaration for Deltex, who make the CardioQ. Briefly, Christian Doppler showed in this equation that you can measure flow velocity from sound waves, and so you're measuring a flow-derived variable, flow velocity. And you can put it through clever electronics, and you see with an esophageal probe placed looking at the descending thoracic aorta, flow velocity time waveforms. And the area of the waveform, the integral of velocity and time, is distance. So that's the distance a column of blood travels down the aorta. If you know the cross-sectional area, then you have the descending aortic stroke volume. Thankfully, when God designed the human body, he designed it with a Doppler probe in mind, because the cross-sectional area doesn't change in systole, which is quite handy. And so that area represents proportional changes in stroke volume, and the proportionality between the upper and the lower body remains the same, so that any changes in this descending aortic stroke distance measurement reflects total cardiac output changes. And there's a nomogram built in the machine that uses the patient's age, height and weight to translate this Doppler measurement into a total cardiac output estimate without the need for measuring the aortic diameter and therefore introducing further error with a further measurement. Is it quick and easy to use? The answer is yes. On average, it takes 1 or 2 minutes to put the probe in. Importantly, in my view, it can be nurse-driven. So on our unit, the nurses predominantly put the probes in and use it, and so they don't need to wait for a doctor to ask permission, can I use it please, or can you come along and use it? So I think the nurse-driven aspect is, I think, an important point. Occasionally you can't find a signal, it's uncommon, it can take more time. So in some patients it can take a few more minutes to find a good signal. There is a rapid learning curve. As with any device, you need to know how to use it properly. And you've got to go up that learning curve. It doesn't take long, but it is important to do so. And there are a few simple rules to observe with regard to correct positioning of the probe. So in a normal-sized adult, you put the probe in 35 to 40 centimeters from the teeth, a little bit higher or lower for a tall or a short person, and you get a well-defined characteristic waveform on the monitor, and with the loudspeaker you can hear the characteristic sound. And that's what you should be looking for. Obviously, if you're too high up, you may pick up the pulmonary artery, too low down, the celiac axis. You can, if the probe is looking anteriorly, you may pick up flow within the heart. You see a continuous venous flow pattern, sometimes with the azygos vein, or sometimes, again, if you're too high up, you may pick up the ascending aorta, but here the flow is going in the opposite direction as it's coming towards the probe. So it's easy to navigate and look for that perfect waveform. Is it safe? Well, it's minimally invasive. You don't need any vascular access. I've yet to hear of any reports of perforation of the esophagus or major bleeds. You can use it with other tubes in the esophagus, NG tubes, temperature probes, tonometers. Clearly, just like with any nasogastric tube, orogastric tube, you've got to either take care or sometimes avoid the use if the patient has pharyngoesophageal pathology. So, it's just common sense, just as you'd use a nasogastric tube. In our practice, we have lots of hem-oncology patients who are routinely thrombocytopenic, coagulopathic, and we're quite happy to use the probe in these patients. Or in our liver patients, we get lots of those, and again, we've not had problems. Are there limitations? Yes, as with every device, there are limitations. It's mainly used, certainly in our practice, in intubated patients. You can place the probe nasally, which is more comfortable in an awake patient. As I mentioned before, if the patient has known pathology, you've got to take care. The probe may move, or the patient may move, or be rolled or whatever, so you may need to refocus the probe. Occasionally, if there's a large hiatus hernia, the probe may flop about, but usually the esophagus is a collapsible tube, so it helps to hold the probe in place and give a good surface contact medium. Clearly, because you're measuring flow in the descending aorta, if you have a balloon pump there creating lots of turbulence, the Doppler won't measure accurately. If you cross-clamp the aorta during vascular surgery or use an epidural, you'll affect the blood flow distribution between the upper and the lower body. So the trend following is okay, but the absolute numbers may not be so accurate. The good thing, though, it's unaffected by pulmonary hypertension and thus tricuspid regurgitation, as with any sort of right heart monitoring technique, or changes in arterial compliance affecting the more distal arteries, because this is looking at the aorta, the big artery. Other information. So it's not just size but shape that matters. The cardiac output is 2 litres a minute. What do I do? Do I give fluid? Do I give inotropes? And I think, you need more information than just the cardiac output. And the shape gives that information. So you can derive information on filling, afterload, contractility, if there's flow obstruction, etc. And as I'll show you, you can even detect aortic regurgitation quite easily. That's our picture again. So the mean acceleration is the upstroke. The peak velocity, and the point has gone, I'll use the arrow here, is the apex of the triangle. And these are markers of contractility of the left ventricle. The flow time is the base of the waveform, the cycle time from the beginning of one beat to the beginning of the next. And you can correct for changes in heart rate with using this derivation of Bazit's equation that corrects the flow time to a heart rate of 60. In other words, a 1 second cycle time. So the usual value is about 1/3 of a second at a heart rate of 60. Systole is 1/3 of the cardiac cycle. So the usual range is about 330 to 350 milliseconds. And that value is inversely related to the systemic vascular resistance. So when you have a dilated patient, the SVR goes down and the flow time corrected for heart rate increases. So when you have a septic patient, you're using an epidural, exercise, pregnancy, whatever, that's causing vasodilation, you get this big broadening waveform. On the other hand, when you're constricted, for whatever cause or from whatever cause, the SVR goes up and the corrected flow time goes down. So hypovolemia, cold, too much vasopressor, if there's an obstruction in the circulation, like a pulmonary embolus, the blood's not getting through to the left ventricle, which is therefore acting as if it's hypovolemic. Invoke Starling, he's been mentioned a few times today. He's a professor of physiology where I work. And you can see the beam of wood on the ceiling where he hung his bits of dog muscle. And that's him with his hand in a dog before he got the muscle out, I think. And you can use the Starling curve, and I agree with Antoine's point that I'm less interested in the cardiac output per se, but the stroke volume. That's what it's all about in terms of optimizing circulation. The heart rate tries to compensate. And you can give fluid challenges to get to the top of the Starling curve. So unless the patient's bleeding out quicker than you're putting the fluid in, when you get to the top of the curve and there's no further benefit, then if the patient still needs optimization, fluid is not the answer. You need to move to something else. So therefore, you don't want to underfill the patient, but you don't want to drown them. You want to get fluid just right. And lots of studies now are showing that point. The peak velocity, as I mentioned earlier, is a marker of contractility. And so there's a normal range for age. And so if the patient falls outside what's normal for age, obviously a younger heart can pump better than an older, weaker heart. If the patient's hyperdynamic, the peak velocity is much greater than expected. If they're hypodynamic, there's myocardial ischemia, for example, then the peak velocity isn't anywhere near or it's below the normal expected range for that age group. So when you look at interventions, if there's a reduction in preload or an increase, the predominant effect is on the base of the waveform. When you change the inotropic status of the heart, give a positive inotrope or a negative inotrope, that predominantly affects the peak velocity. And when you have predominant changes in afterload, when you increase the afterload, the ventricle has to pump harder against the increased resistance, so the peak velocity goes down and the flow time corrected gets smaller. When you dilate, there's less resistance, the heart can pump more easily, you see the opposite effect, like so. So just a few pictures. I'm not showing any numbers, but you can just see from the shape. On the top is the patient in atrial fibrillation. After a little bit of electricity, the stroke volume is clearly much better. You can look at, if you want respiratory swings. I'm personally not a great believer in that. Again, lots of advocates, but my view is, I think like Andy said this morning, if you're worried, a little bit of fluid won't harm the vast majority of patients. And clearly, I think certainly the mood in intensive care at the moment is to try and get the patients awake, spontaneously breathing, where there may be issues there. This is just an example of somebody who had a bad heart, who was given the additional kick of atrial pacing. These pictures were taken about 20 seconds apart, and you can see there's a doubling in cardiac output because of the atrial kick. This is a patient having cardiac surgery, and you can see, just following it through, before the patient went on bypass, there's a progressive deterioration in the trace. And at this point here, the patient needed to go onto emergency bypass, but you could intervene at a much earlier point. Why wait until the pressure disappears and everyone gets into a panic? You could intervene if you detect the problem earlier. You can pick up aortic regurgitation if it's moderate to severe, because you don't see this diastolic flow going through the whole length of diastole except with moderate or severe regurg. So this is actually the very first one I looked at, and this is before and after valve replacement. And as you can see, it's still there after the valve replacement. And I was young and innocent, and so without telling the surgeon, I arranged an echocardiogram, and it confirmed that there was a paraprosthetic leak. Ooh, I then told the surgeon, and I'm still alive. But usually you shouldn't see that. So it's better though. He was happy. It was better. I'll give you two very quick case studies because I like anecdote. I know Andy didn't like anecdote, but I like anecdote. This is a 34-year-old bricklayer, muscular guy, whose mission in life was to earn enough money to drink himself silly and inseminate every woman he could get his hands on. I kid you not. He did, though, not behave very well in the few days up to admission. He came in febrile, and he was found moribund in bed on the day of admission. He had papilledema, GCS was low, very tachycardic. He had a blood pressure, 130/50, he had purpura fulminans, and his limbs were like marble. He couldn't feel pulses until you got to the femorals. And that was him a few hours later, but it was pretty nasty. Yeah, nasty. Diagnosis, yeah, meningococcal septicemia. So what we're going to do, essentially in the emergency room, he was intubated, mechanically ventilated, blah, 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 sugar was all right, bloods. He was given colloid, young man's meningococcal sepsis, antibiotics, and they called for the 7th Cavalry, the intensive care. So we came down, trotted down, and I said, what did I say before I went down? Don't give him any more fluid. Why? That's what kills these people. The young meningococcals often have severe myocardial depression. Clearly, getting him into a bed, he's potentially infectious, needed a side room, so you're not going to rapidly move him. So the beauty is you can monitor him very, very quickly. So I don't have the actual pictures to show, but we've got the numbers. So he was tachycardic, he'd now been intubated, blood pressure was lower, the CVP was 12, the stroke volume was 22. Not very good for a young, strong man. A gentle 200 ml fluid challenge made things worse. His stroke volume fell to 15. Is fluid the answer? No. 200 mils did that. So, plan, no more fluid. So he had, I'm a great believer, a big dose of steroids in these patients. That's a separate talk. Started some epinephrine, started some nitrate to try and open him up as well. But in fact, I think the steroids were probably what did it. But because within 10 minutes, his cardiac output had tripled. It was up to about 6.7, and concomitant with that, he was actually looking better. The blood pressure was holding his colour. He was pinking up. You could visibly see him pinking up. And I won't bore you with all the rest of the treatments, but that was him 10 days later. He went back to Manchester to carry on inseminating women. I kid you not, literally about six separate women turned up worried about would they catch meningococcal sepsis. We'll go from the sublime to the ridiculous. Let's go to a priest. So this is a guy, God was on his side. God and Doppler, obviously. He came to us after an elective AAA aneurysm repair. He had a good history of, no history of heart disease. He had a preoperative ejection fraction, which in my mind is a stupid thing to measure, of 50%. 50% of what? We don't know, but 50%. Yeah, I'm glad you like that one. The surgery was unremarkable, well it always is. There was low blood loss. He dropped his blood pressure at one point of the operation. They gave some fluid, it quickly came back. At the end of the operation, he was 2 litres positive, 2.5 litres in, estimated losses 500 mils. However, when he arrived, he was tachycardic, 140, blood pressure 150 over 100, the CVP was 8. He was passing lots of urine, no furosemide, allegedly. And he was acidotic, -7. And the resident gave him some colloid and gave him some opiate, just in case it was pain or hypovolemia. But an hour later, he was still tachycardic, hypertensive. The CVP was now 13. He was still passing good urine, but he was more acidotic. What do? Do you vasodilate him? Give him an inotrope. Give him fluid. Give him a beta blocker. Go and have a cup of tea. The Doppler, though, showed a low cardiac output, about 2.5 litres per minute, with a very, very narrow corrected flow time. 159 milliseconds. If you remember, normal is about 330 to 350, 360. So it suggested he was empty. A fluid challenge, got a bit better, and then it got worse again. Ergo, give him more fluid. And after an hour, he'd had 2 litres of fluid. His cardiac output was a little bit better. He was a little less tachycardic. He still had a good blood pressure. His CVP was 8, despite the 2 litres, so it had come down from 13 to 8. He was still passing urine, more acidotic. We were waiting for some blood, but the hemoglobin was now 8.4. What would you do at this stage? Call the surgeon? Yeah, let's call the surgeon. And they weren't interested. Perfect operation. It's your machine. What can you do? Anyway, so we continued, the good intensivists that we are. And after 2 hours, he'd had a total of 5.2 litres of fluid. Now he was getting blood as well. Cardiac output now was a lot better. Heart rate was down to 97. Blood pressure, 110/70. CVP, despite 5 litres of fluid, was 12. He was still passing good urine. Acidosis was a bit better, obviously getting blood. And there's the sort of, you can see the pictures. It got better, got worse, more fluid, got better again. We called the surgeons yet again. The abdomen was obviously distended. And they reluctantly, it was literally a gun to the head, and they agreed to operate. And there was a hole in the common iliac. And 5 litres of blood, whoops. And the hole was repaired and the patient did well. The morals of the story, I think the prompt intervention made a difference. I'm sure eventually the penny would have dropped, that would have been recognised, but the fact that we got onto it proactively rather than reactively when he was in shock, I think, or at least hypotensive shock, was averted. And the other moral is never trust a surgeon. I'll finish there. So in summary, I think it's a nice, easy, quick tool to assess the cardiac output and other useful hemodynamic variables. Yes, you may need to refocus the probe. There are some patients you can't use it in or shouldn't use it in. I think certainly, you know, the emphasis of what we do and what we teach our juniors and the nurses is to look at dynamic change, to look at the response to fluid or PEEP or straight leg raising or whatever, and assess the response. And you can see this online. Again, emphasizing the point of the learning curve. People need to know any device, how to use it properly to avoid rubbish in, rubbish out. And I'll finish there. Thank you for listening.